Imagine what 1 million healthcare professionals could do if they worked together to shape the future of our healthcare industry. Introducing the Global Health Impact Network, a clinician-driven, collaborative network of communities focused on healthcare innovation. Through intra-organizational, intra-community, and inter-community collaboration, GHIN enables healthcare professionals to become leaders in healthcare innovation at the precipice of the evolving digital healthcare revolution. Clinicians, C-suite administrators, and others can actively participate in all aspects of the healthcare continuum. Healthcare organizations, including hospitals, academic institutions, and nonprofits, can securely and safely share their ideas and innovations on our platform so that healthcare professionals can create a future of improved access to healthcare, improved care delivery efficiency, and safety while decreasing the spiraling healthcare costs. A pediatrician can interact with top experts to access and learn best practices when approaching pediatric oncology or chronic disease management. A doctor can engage with early-stage healthcare technology companies through our partnership with the Global Health Impact Fund. No matter the purpose, every member has a wide variety of opportunities to ensure active involvement. Please contact us if you are interested in joining our growing clinician-driven global healthcare innovation network. Together, we can shape the evolving digital healthcare revolution. The Global Health Impact Network. Imagine the possibilities.
Hey, good afternoon or evening, everybody. I so appreciate you being here. This is a great opportunity for us to get into some of the opportunities that the Global Health Impact Network has to offer. I'm Paul DeChant. I'm the COO for GHIN. I also dedicate a lot of my work to reducing physician burnout. In my career, I've been a practicing family physician for 25 years, actually had many management roles in healthcare organizations, actually led a 300 physician group through a transformation that not only got us recognized as the top performer out of 170 groups in the state 2 years in a row, but moved our physician satisfaction scores from the 45th up to the 87th percentile. And I'm looking forward to this opportunity to share with you some of my thoughts about how to reduce burnout by reducing the drivers of burnout while getting into a conversation with you about how this can apply in your setting. So without further ado, let's go ahead and get into the presentation. And we'll get started. This is really the goal here is to talk about how we empower not individual clinician resilience, but organizational resilience. How do we address those root cause drivers of burnout? And I like to start not by thinking about burnout, but by thinking about the opposite of burnout, which is professional fulfillment, which we particularly as physicians can find in many different ways. Certainly the most common is when we're caring for our patients, when we can be deeply connected to our patient and we're making a difference in that patient's life. But we also find professional fulfillment in doing procedures that make a real change in a patient's health, or educating learners who are coming up through the ranks and are going to be joining us as colleagues, or doing research that creates new knowledge that we can then apply in all of these other realms that we just discussed. All of those are when we're in those zones, we get deep professional fulfillment. The problem is we spend too much time in other realms dealing with administrivia and the like that pull us away from what's truly satisfying for us. In fact, that's what drives burnout. And as Maslow and Leiter, two of the creators of the Maslow Burnout Inventory, describe, they say that when they see burnout, they see a sign of dysfunction in the organization, and that it says far more about the workplace than it does about the workers. Now, in healthcare, you may wonder, why is that? But the fact is that healthcare is one of the most challenging and difficult organizational industries to manage. It's so complex, and even Peter Drucker, a famed management consultant, recognized this years ago. So the challenge is, how do we, in these highly complex organizations, address burnout? Well, let's start by understanding what burnout is. There are three key manifestations to burnout. The first is exhaustion. When exhaustion happens, it means we've lost our enthusiasm for work. We've given all we can. We have nothing left to give. You know, when we get to that point, then we experience the second manifestation of burnout quite commonly, and that is depersonalization or cynicism. Now, oftentimes that's just a reaction to that point where we've got nothing left to give, we're basically protecting ourselves from our organization or our patients. But when we protect ourselves from our patients and our organizations, when we have nothing left to give, we start to feel as though we are not making a difference. And I think that's the saddest of the three manifestations of burnout, because clinicians invest their entire lives into developing the knowledge and skills they need to provide great care. And on almost every patient interaction, the patient greatly values that. But oftentimes we've gotten to the point as clinicians, we don't recognize that value in every single interaction because we've had thousands, if not tens of thousands of them. It just doesn't have the same impact when we are burned out. So what's driving all of this? What drives burnout? It's basically a result of the interaction between a worker and a workplace, where we put highly motivated workers into dysfunctional workplaces that require constant vigilance and focus in order to effectively function, in order to not make a mistake. And those kind of conditions can work for short periods of times, but they're not sustainable in the long run. What happens is we're constantly exposed to work overload. And particularly in healthcare, we have chaotic work environments and incredible time pressure and increasing information overload, with information doubling every 73 days before the pandemic hit. So if work overload is the first driver of burnout, look what it leads to. It leads to a sense of a loss of control, which is the second driver of burnout. Control is a big deal to us as clinicians. We do a lot of training, we get a lot of experience, so we can take control when need be. Our patients want us to. In fact, control is one of those intangible rewards we look for when we join this profession. And in fact, insufficient reward is the third driver of burnout. Now, there's other rewards we look for: professional recognition and the ability to connect with our colleagues. That collegiality is so important. And yet what we're finding is there's breakdown of community. We're not connected to our colleagues as much. And that is the fourth driver of burnout: breakdown of community. When we get disconnected, we're overloaded, we're stressed and unrewarded. We start to feel as though this is not fair. And in fact, absence of fairness is the fifth driver of burnout. So much of the healthcare workforce today faces this at a level that I personally, as an older white male, I call myself a pale stale male, I have not experienced that lack of professional respect simply because of the color of my skin or my gender or my country of origin. But so many of our healthcare workforce today do experience that, and it's totally undeserved. In fact, we sometimes start to wonder if our personal values align with the values of our organizations, and that conflicting values is indeed the sixth driver of burnout. So all of these drivers of burnout come together. And what Maslow has shown is that there's a direct link between the drivers and the manifestations. In fact, the work overload drives emotional exhaustion. And surprisingly, those other five drivers are what drive cynicism. Now, if we can overcome those, what we can find is that by overcoming work overload, we can create the opportunity for discretionary effort, to actually invest more effort into process improvement, into safety, into access. And if we can overcome cynicism and drive engagement, well, we can create a much better, healthier organizational culture in which we can all thrive and feel supported. You know, I found it really interesting to think about the relationship between Maslow's hierarchy of needs and Maslach's drivers of burnout. And when you reflect on this for just a minute, you can see that work overload really drives that issues around the base hierarchy of need, that physiologic need. When we're working so hard, we could barely have time to eat or drink, let alone go to the bathroom. Our physiologic needs are not being addressed. When we're lacking control, then we're putting our safety at risk. When we're not being acknowledged, rewarded, or having a sense of community, that whole sense of belonging is really challenged. And when we're dealing with issues of fairness and values, well, self-esteem and self-actualization, just become all the harder to realize. So all of this ties together into the experiences we have as human beings as we're doing this work. So it's pretty bad. How did it happen in the first place? Remember, we put a clinician inside a clinical workplace, and the clinician's interacting with that workplace, and that workplace is chaotic and challenging. Why is it like that? Is it because people who have the highest level of control over the workplace, the administrators, just wake up every morning thinking, what can I do to make the workplace miserable for my clinicians? I don't think so. I've been an administrator. I woke up every morning wondering, how the heck am I going to deal with all of the external factors that are impacting the workplace? How do I best deal with, so I can support my clinicians, deal with the EHR, the HCAPs and CGCAPs, maintenance of certification, changing patient demographics, violence creeping into the workplace, you name it, so many factors. All of these have come up in the last 15 years or so. And the impact they have had is that one by one, they've ticked away at us. We could absorb each one a little bit at a time, as long as we could maintain that important connection to professional fulfillment. We could connect to our patient, we could do our procedure, we could teach our learners, we could do research. If we could maintain that, we could suck up the EHR, we could suck up dealing with the opioid crisis, we could deal with changes in coding, we could deal with insurance companies. But we've reached a point where all of these are collectively too great. And in fact, we've added the last straw, and people are breaking. When people break, we see the impact of burnout. Productivity declines, presenteeism increases, injuries and depression happen, substance abuse and family dysfunction, and ultimately suicide. You know, there are 300 to 400 physician suicides a year in the United States. That rate has not declined despite all of our attention to burnout. This is a call to action as significant as the pandemic when you think about the threat to clinicians when they're exposed to these conditions. Now, that may be, but what happened in addition to all of those other factors was, in this past year, we did have the pandemic hit us, and it overwhelmed everything else that was involved. And when it did that, it created this VUCA environment, an environment in which we deal with volatility. Things were so changing so rapidly that they created great uncertainty. It was really hard to know what were true risks and what weren't. It was very complex. There were so many variables involved, and it was highly ambiguous. There was no clear right answer. For those of you not familiar with it, that VUCA environment is how the military describes combat. And the intensity with which soldiers go through combat is now the intensity of experience that our healthcare workers have had as they've been on the front lines of the pandemic. The impact of that has been even further than the impact we described previously. Such fear and anxiety, morbidity, mortality, isolation, loneliness, further disruption of family and friends, financial uncertainty as people lost jobs or were overworked, or many other issues took place. The moral injury of being exposed to these dangerous workplaces, and the risk we now stand of seeing PTSD as we begin to finally, hopefully, come out of the highest levels of severity of the surges, and people get a chance to catch their breath and realize what's happened. So this is pretty overwhelming, and the question then becomes, what should we do? How do we deal with all this? What I like to propose is a 5-step approach that's based in large part on the recommendations that have come from experts in this field, like Dr. Tate Shanafelt, who's the Chief Wellness Officer at Stanford and has been leading the Chief Wellness Officer movement across the country. Because it takes a comprehensive approach in order to support the vast majority of clinicians who work in our large institutions. It's going to take institutional commitment, but we can get there. And that approach includes these 5 steps, and we'll go through each of these in detail. The first is a diagnostic assessment. If we're going to develop a treatment plan for this problem, we need to diagnose it correctly. So those assessments should include burnout surveys, Also, performance of the organization, including the financial performance. If we design a process to fix this in a way that's not financially sustainable, we might as well not do it because we will not be able to deliver it in the long term. We need to understand the quality of leadership so we can identify where we can support that. We need to understand how well the EHR is being deployed and used so we can understand where to make impacts there. And ideally, leaders, particularly non-clinical leaders, need to understand the actual situation where care is being delivered. They need to shadow clinicians to see the reality of the impact of the decisions that get made in the C-suite and the boardroom. Once we have that information, then we can use it to design a burnout prevention and treatment plan. This is such a big impact on the organization. It should be given the same level of import as a strategic planning session. Top-level leadership should commit 1 to 2 days to this. That should include the CEO, their direct reports, and physician leaders from across the organization. That process should decide where and how to focus the impacts based on the diagnostic, and those plans should include specifically how to improve worker well-being support, how to improve workflow efficiency, and how to improve the management system and culture to create that type of support that's so important. This will include, following up from developing the plan, actually regularly reviewing and tracking the implementation of the specific steps recommended in the plan to be sure that they are happening, and tracking the results to be sure that we're seeing change happen. There's a real impact for the people on the front lines, that it's not simply putting these measures into place and just trusting without tracking that indeed this work is happening effectively. What should take place for well-being support? Well, every organization should have a well-being committee that's actively engaged. Perhaps it should be called a task force or something more active than simply committee. It should be providing education and peer support, communication workshops, support for stressed colleagues, resource for individual support, providing coaching or counseling. And it should be involved right from the very start when somebody joins the organization in the onboarding process. And this is tremendously important because even if every workflow was perfect and the management system was ideal, we still deal with life and death issues. We still deal with heavy emotional challenges. We will always need well-being support because what healthcare workers get exposed to are significant issues that the vast majority of other workers do not get exposed to. We need that kind of support in order to deal with the type of moral injuries that come from being exposed to the negative impacts of caring for people who are really dealing with life challenges. But we can do a lot to reduce the other impacts. A place to start is improving workflow efficiency so that clinicians no longer feel like this poor fellow that you see running madly on this wheel. In fact, it wouldn't surprise me if I turned this into a video that he would fall off because it was just going so crazy. We have turned our highly skilled knowledge worker clinicians into data entry clerks who are doing administrative tasks that others could do. We're wasting the tremendous capacity that we as clinicians have to actually spend the vast majority of our time focused on our patients, not focused on paperwork or keyboards. We can do this by redesigning the way we do our work. And when we do that redesign, it should be done involving as many different people as possible in the flow of all the stakeholders in the flow of those workflows. We want to get clarity about what the problem is. And in order to do this well and to come up with the great ideas, we need to have everyone involved. Now, as things have become more remote, this can be a bit more challenging, but there's great whiteboard software out there that we can use to do this. The key is that we should have highest level clinicians participating, including physicians. Because when physicians tell me they're too busy to get involved in this work, I'll ask them if they ever take a vacation or if they ever go to a CME conference. Because when they're on vacation or at CME, they're not available for their patients. They're not available for their colleagues who they feel they must be available for. But you need that break. You need to get the rejuvenation of time away. You need to learn new knowledge. And yet when you return to your practice, Within a half a day, if not a half an hour, that rejuvenation is gone because things are so crazy. And it's so hard to implement new ideas and new knowledge because you're working in these chaotic workflows. The most important time that high-level clinicians and physicians spend away from their practice may well be the time they spend redesigning this practice. That continuous improvement work, it's all about empowering workers to solve their own problems. It's not about having an outside expert come in and tell us what we should be doing. It's about an outside expert whose expertise is in coaching us through the process. So we can fix broken workflow processes and eliminate these frustrations, but that should be led by the people who do the work in their work sites. We know what's wrong. We have great ideas. What we need is somebody to guide us through the process by which we can identify collectively what's wrong and collectively identify what are the most effective ideas to put into place and then begin to track them. When we do that, this approach is essentially the same, whether you call it lean or design thinking or innovation, I don't care. It's all basically the same approach. And that's so empowering and creates these opportunities to just redesign workflow and allow us to spend more time focused on what's most important to us: patients, procedures, education, research. To help that workflow efficiency process move most effectively, we need a management system and culture in place that supports that. This is often the hardest thing to push for, to achieve, because we're talking about a completely different approach to leadership. I like to describe this as lean leadership, and yet when I do so, quite often people will say, "Paul, you're crazy. Lean is mean. I've seen lean make things worse, and it will if lean is focused on productivity." That's not what's most important. What's most important in a healthcare organization is the patient and the connection that frontline caregivers have to a patient, where every interaction has the opportunity to be a healing interaction, to reduce anxiety or worry, to relieve pain or suffering, to do a definitive procedure, to educate people to be healthier. For myself as a family doctor for 25 years, I had close to 100,000 healing interactions. As I moved up in management roles, I actually got farther and farther away from that most important work. And ultimately, as a CEO, I no longer saw patients. I was no longer doing the most important thing for the most important person in my organization. My job was to make sure that the people who I supported were laser focused on helping their frontline clinicians to interact with their patients as effectively as possible. That's what leadership is all about. Leaders' roles are too important to ignore because leadership is so powerful. As leadership quality improves, burnout decreases. Leadership development programs are key. And leaders have to be visible, because if a leader is espousing something but not there to stand up for it, others will not follow it. People only pay attention to what the leader demonstrates is important to them. So leaders need to be out at the front lines, shadowing workers, attending huddles, not to come with solutions, but to help everyone learn, identify what the problems are, and then help them develop the solutions that they identify will work best for them. Another challenge is around all these issues of misaligned values. So attention to the organization's mission, vision, and values becomes vital. One way to do this effectively is to create a compact that's based on those values. And a compact is a document that actually describes a reciprocal relationship between the people on the front lines who are providing care and the values espoused by leadership. So that if there's a specific way that a worker honors the value, say closes care gaps at every visit if quality is the value, that there's this reciprocal agreement that the organization will provide the staff or other support needed so that that worker can actually do that task effectively. And when we develop that, then we actually create a unified organization, and we can use that mission statement, vision statement, and values and compact to drive difficult decisions. If there is a provider who's not really supporting the way that we as an organization believe we should be collectively working, we can use our value statement, our compact, to help guide decisions on how to manage those issues. We can use these to guide strategic decisions, not based on one person's pet interest, but based on the organization's best interest overall. Another key factor in management systems and culture is our huddles. And keys to effective huddles include, they should only be 15 minutes. They should be ideally standing up at a huddle board. These days, as they get more remote, they might be sitting down, but they should not lose that sense of urgency you get when you stand up. They should include a minute for acknowledgments and appreciations. Remember, insufficient reward drives burnout. We should prepare for the day. Do we have the capacity to meet the demand? Can we solve problems? What little thing went wrong yesterday that feels like a little pebble in your shoe drives you crazy? We can actually address those in these huddles, bring them forward, and make sure we don't forget about them because we're overwhelmed with other things. And we track performance of our frontline caregiving unit along the metrics that the organization as a whole has set as most important, so that we understand how we make improvements and they contribute to the overall organizational quality. It's those true north metrics that are here: quality, safety, delivery, cost, growth, and human development, employee engagement, that we track at the front lines and make an impact for the organization overall. When we put this system in place and we have daily huddles happening at the front lines, you see up in the upper right there, the staff and supervisors huddling together, using that system of preparing for the day, tracking performance, identifying and fixing problems, and then escalating those issues that can't get solved at the local level through a series of steps from the front line to the C-level executives. Then we can actually make sure that whatever issues are truly serious don't get ignored, don't get lost, and that the C-level executives are never surprised by something that happens a month after it became a problem. By the same token, the C-level leaders must commit to sharing their mission, their vision, and the values, and driving those and communicating those out to the front lines through leadership teams that are empowered and developed, ideally including dyads or tribes, not just a physician leader, but also an administrator in clinics, or an administrator, a physician, and a nurse in the hospital, so that we've got the power of the combined leadership team working together. And when we do that, what we create are ways that we can significantly reduce burnout while providing major competitive advantages. In a sense, it creates organizational resilience. We have a healthy organization full of empowered and aligned problem solvers who will then quickly adapt to those VUCA environments, that volatility, uncertainty, complexity, and ambiguity. When we can make changes rapidly and adapt like that, as we saw so many organizations do when COVID first hit, then we have created organizations that rapidly adapt to external environments. And isn't that what Darwin said was key to our success long term, to be the ones who survive? I know this works because, as I said, I led an organization that over 5 years made the kind of transformations that allowed us to be recognized as a top performer in the state 2 years in a row, while we moved our physician satisfaction from 45th to 87th percentile. To step away from the data and let's just look at the human impact. Here's the kind of experience that others have had when we've coached them through these same changes. This is a primary care doc in a small town in Georgia, working for part of a larger system in that area. He said he didn't know how long he could continue to work as he was. This gentleman's 35 years old. But after going through this redesign, after experiencing this new culture, he realized now he could continue to practice because he had time for himself and for his family and was in a supportive environment. He knew he could practice really for the rest of what he wanted his career to be, 20 or 30 years. That's what this is about. The human impact on our clinical workforce are incredibly valuable people who've committed their lives to caring for our friends and neighbors. There's no reason we can't do that as well. So that's it. With that, I would love to open this up for any conversation that others would like to join in. And I'll just leave it there and welcome your opportunity for that conversation. You've got my contact information here. Please, I look forward to hearing from you. Thanks. So I see one question that came in here from Jose Bolinas. If there is a problem with the committee, a doctor has to get an attorney and sue the group. The group is legally funded by the hospital. So Jose, I'm not exactly sure what that question is alluding to. There's so many factors there. Some medical groups are independent, others are closely aligned with hospitals. Certainly there's doctors who feel that they're not being treated fairly and may well consult an attorney for that issue. And when that happens, certainly groups will turn to attorneys as well, considering who's funding which. That's a whole other question. I think what the question does speak to, though, is this issue of group culture, and does that group have a culture that's designed in a way that it really nurtures support for the frontline clinicians? And are the clinicians feeling as though they have the opportunity to participate effectively? There's an awful lot there, because many groups at this point have gotten to a level where there's a huge disconnect. And in fact, the disconnect between frontline clinicians and administrators in many organizations has never been wider. That's not always true. There are other organizations where they've worked intensively on this, and they actually have great connections between C-level leaders and medical directors and the frontline clinicians. But it's not as common. As healthcare has become more corporatized, it's been easy to let those relationships slip. So where's the opportunity there? Well, if something's deteriorated to the point where both parties are suing each other, that can be a real challenge to recover from. And whether or not that individual relationship is recoverable, I'm not sure. I'd have to know the specific conditions and information in that specific case. But from a standpoint of, can we actually do something proactively to prevent that from happening? Well, that's a lot of what I'm talking about. And there may well be cases where much of the organization, much of the frontline clinicians really feel disempowered, disengaged, disrespected. But it hasn't gotten to the point where everyone is suing each other. There's opportunity there. There's opportunity there if leadership is willing to listen to the front lines to understand where that disengagement comes from. And front lines are willing to engage with leaders to participate in solutions. And again, it depends very much on the individual situations there. But there is opportunity there, and I'd be happy to talk to you individually later to see if there may be some other way I can further answer that, or even potentially give you some guidance on a specific case. And if we want to go into further discussion on that, I'm certainly happy to do that right now as well. Do we have any other comments or questions? I'm not seeing any come up, but I'm not sure if that's because there aren't any, or if our support staff is just, having a challenge getting them up there. But I'll give it just a little bit more time to see if there might be an opportunity. I think I can talk about some other resources to consider, particularly around this whole issue of of organizational culture and leadership, because there's a lot of great resources out there. There's a book I like to refer to that talks about how leadership can really engage well with frontline clinicians. The title of it is Everybody Matters, and it's by the CEO of a heavy equipment manufacturing company. The company is called Barry Waymiller. The CEO's name is Bob Chapman. And Bob was a pretty traditional CEO that had a very top-down management approach with a company that's based in St. Louis and makes heavy equipment like bottle washers for Budweiser. He had this insight that he could actually really change his company culture if he were to find a way where everybody in the company treated each other with the same care and concern they have for their close friends or family. And as he did that, what he found was that it made a huge difference. He started it in his main office in St. Louis, but he has 80 companies in 17 countries, or 80 plants in 17 countries around the world. And he wanted to spread this across all of them. And he actually found Lean as the management system by which to spread this leadership culture. And in the process of doing that, he created a company that actually outperforms Warren Buffett and Berkshire Hathaway on return on equity, because these unleash the power of every single person in the organization. So if you're interested in this stuff, it's a great book to read. It's the book, name of the book is Everybody Matters. The author is Bob Chapman. And in fact, Bob spoke at the last in-person live American Conference on Physician Health about a year and a half ago in Charlotte, North Carolina. He received a standing ovation. He was amazing. And he's a great person to learn from. And if you've got other questions about that, I'm certainly happy to follow up with you later on that as well. So I saw one note thanking me for a great presentation. Thank you. I really appreciate that. Any other comments at all or questions at all that we can cover? And if not, we could certainly think about starting to wrap up. We have time to keep going for longer if you'd like, though. You know, sometimes when I'm finishing something up and I'm about to move on, particularly in the middle of a presentation, I ask an open-ended question. I'm not hearing a response. In these days of these online virtual webinars where we can't really see each other, I'll make sure that I don't wrap things up too soon. Because oftentimes if people are like me, they're hanging back, waiting, thinking somebody else has a better question to ask or a more insightful comment. So before I go on to the next thing, I'll say going once, going twice, and let's move on. And that gives people a chance, if you're like me, to speak up before the chance escapes you. So, oh, here we go. Good. Larry Cooper, what about medical school burnout prevention course? Great question, Larry. Thank you so much. This definitely needs to be addressed in medical school. There's, as many of you probably know, medical students, as they enter medical school, are as healthy, if not more healthy psychologically than their non-medical counterparts. But there's something about the nature of this medical training that really has a big impact on us. And I think it's multifactorial. Some of it's the competitiveness by which we get put into this very competitive environment because we're all working towards getting the best possible grades, getting the best step scores, whatever it takes in order to get into that residency of choice. And then when we get into the residency of choice, depending on how far we want to go with our career, we may be competing with our residency cohort colleagues to get into that fellowship of choice, to get into that position either with a prestigious medical group or a faculty position, or even just trying to find the best position where our family wants to move to. And so we live in this very competitive environment. On top of that, there is still far too much hazing that goes on in medical education. And we really need to educate medical students about this early on so they're aware of it and can create support groups and other ways to manage that, as well as to educate faculty and redevelop medical college cultures so that we eliminate these types of situations. There is no reason that people need to be hazed or, you know, as the term is, being pimped in order to ensure that you're learning the knowledge you need to learn. And when I first heard that term, you know, I thought I knew what it meant. I've actually just recently seen that pimping can be an acronym. PIMP stands for put in my place. It's a way that those above us in the medical education hierarchy may put those below us in the medical education hierarchy in our place to make them feel somehow worse. Because in many ways, in many cases, because that's what happened to those of us who've gone before. It's not right. It shouldn't continue to happen. You wouldn't think we'd want to do it to others because it had been done to us. But it's still pervasive. And it's something that should not be tolerated. I guess if there was one thing we could get rid of right away, or at least make very clear from top level leadership in our educational institutions, is That cannot be tolerated. Bullying cannot be tolerated. Microaggressions based upon those other issues, whether it's things that don't relate to your actual capability, but simply are your own personal identifiable issues, your race, your gender, your country of origin, those should never be factors that enter into how people view you. But all of those are too pervasive. So if we could do one thing, I'd say if medical schools and educational institutions focused on that and eliminating that, that would be so powerful. That said, there's many other factors involved, and I think education courses for medical students as they're coming in make a difference. Developing support groups for students as they get started is important. I was very fortunate back in the 1980s when I started my residency in a small community practice, community hospital residency in Colorado. We had a very forward-thinking practice residency director. He actually engaged with a clinical psychologist to give our cohort a weekly support team meeting, which was tremendously helpful to me in helping me get through some really challenging times. Those kind of activities are important. They're still not universally available. Those are great ideas. There's many things we could do. So I really appreciate that. That's a great comment. Another comment, what about burnout in nurses? Yes. Well, burnout, it's actually demonstrated now. Nurses see the same rates of burnout that physicians see. So there are some things that we all have, different aspects that are related to that, and some are similar. I mean, there's this common expression, that nurses eat their young. I mean, nurses are also known to be abusive to new nurses coming out just as much as doctors can be abusive to students and residents developing. So we all have to think about that culture and find ways to become supportive. Nursing, and there's many of the root cause issues are the same, but just as the root cause issue for burnout in a primary care doctor working in a small clinic somewhere are very different from burnout for an ICU physician working in a large academic institution. Burnout for nurses can vary, not just between doctors and nurses, but between the clinical situation the nurse is in. So when you get right down to it, the key issues still remain: do we get the support we need? Are we able to focus on what's most important to us? And can we work to reduce those things that aren't important, that data entry, administrivia? Can we create a culture that's mutually supportive? When we think about it from those standpoints, we can identify the specific issues activities we can take to address what's happening in each specific situation. What about CME credit for burnout prevention? There actually are ways that this is happening now. Many organizations, when in national meetings, whether it's of a professional society or of a quality improvement organization, will have CME available for courses that talk about how to prevent burnout. So this happens at IHI. In fact, I know the American Academy of Family Physicians is putting on a whole conference just around preventing burnout. I actually had the pleasure of doing a keynote speech there 2 years ago, and now that we're doing a virtual one this year, I'll be presenting some virtual workshops there. There's a number of other great physicians as well as other professionals that are presenting at that conference as well. In addition, many specialty society general meetings will include some CME accredited presentations on burnout. I've given a number of those as well. So yeah, it's a great idea. And in fact, where I see a lot of work on this happening is at state and local medical societies. Many of those organizations have made great commitments to this. And so this is another resource to look for. If you're part of a large group, you may find these resources through your group. But if you're not part of a large group, your state and local medical societies actually are very actively engaged. In fact, the American Medical Association at a national level has made significant commitments to this. About a third of their strategic plan is now focused on reducing burnout. They've created a website called Steps Forward where you can get CME credit for participating in that. They sponsor every other year, the American Conference on Physician Burnout, where you get lots of CME credit there. They co-sponsor the international conferences on physician burnout in conjunction with the Canadian and British medical associations. Credits are available at those as well. So there's a whole array of those opportunities. In fact, others to think about the American Association for Physician Leadership. While they educate physician leaders across a whole realm of leadership issues, they have a significant focus on burnout, and you can get CME credits there as well. How about comparing burnout in ER physicians versus clinic physicians? Yes. So there's a couple of things to think about there. Medscape is one of the well-known organizations that surveys physicians and then puts out results of those surveys and compares burnout rates by different specialties. And year by year, they'll vary somewhat, as well as there's oftentimes some consistency. ED docs consistently rate pretty high on those levels, but so do primary care doctors, family med, internal medicine, and peds. So there's different sources of the burnout, but in terms of rates of burnout, they're actually fairly consistent. Now, in this past year, with the pandemic, we've seen some of those specialties shift a bit. Actually, urologists used to be some of the highest levels. They've decreased a bit through the course of the pandemic, but the rates are fairly similar. What's driving it? Well, ER, as we know, is a completely different practice than primary care. So there's different things at the core that are driving it, and this is where it's important to look at your individual workflow in your individual practice and understand what's working and what's not there. But the opportunities to identify ways to help clinicians manage work in the EHR more effectively, to build support staff around physicians, to reduce data entry burden, to allow us to really address what's most important for a physician, for the patient care. Those concepts are the same. It's just a matter of deploying them differently depending on the clinical situation that you're in. Great question, Jose. Thanks. So, any other questions at all? It's been a good facilitated discussion. I really appreciate it. And I'm looking at myself frozen on the screen. I don't know if you can still see or hear me. But if you've got any other questions, please feel free to jump in. And if not, I wish you a great afternoon. I'll do it one more time just in case I'm still on. Going once, going twice, anything else? If not, I'll say thanks and say good evening, everybody. Take care. Appreciate it.